Behind every great outcome is the sometimes invisible choreography of nursing work. Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from leading clinicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcast, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adibuya. Today's guest is Dale Beatty, Chief Nurse Executive and Vice President at Stanford Health Care, with more than 20 years of executive nursing leadership in high-performing organizations. At Stanford, he leads the system-wide integration of caring science across nursing practice, education, and research, work that earned Stanford national recognition as a National Practice Caring Science Exemplar and the 2022 ANCC Premier Award. He earned his Bachelor's of Nursing from Ohio Wesleyan University, a Master of Science with distinction from DePaul University, and a Doctor of Nursing Practice from the University of Illinois, Chicago. Thank you for joining me on the podcast today.
Appreciate it, Ruth.
A great place to tee up our conversation is to talk about the context in which you operate. We have heard about a nursing shortage, and when leaders say that, what do you believe is actually scarce? Is it the people? Is it time? Or is it attention?
That's a complex question, and I would respond by saying probably all of the above. Every market is a little different, so you have to be careful about generalizations. I've been a chief nurse for 25 years of my career, so the majority of my career has been in the chief role. And so much of the role really does involve workforce and workforce development, professional development as well. But when you say people, time, and attention, all of those are critical. What I have found here at Stanford Health Care is not the people portion. I think in other places of the country, that may be the case, but I'm a big believer that a lot of it goes into developing a healthy practice environment that people want to stay at. The reason I say that, Ruth, is during the pandemic, when there were a lot of workforce challenges and changes, we found that we had an increase of travelers with the vacancies that we did have. And a lot of the travelers chose to stay at Stanford Health Care. We're sitting now with a vacancy rate and turnover rate of less than 4%. So we're fortunate. It's not a people thing for us. It's about making sure it's a practice environment people want to be a part of, feel proud of, feel resilient, and feel like they've made a difference. Oftentimes you'll hear the term burnout, and they're talking about, I think, when they get too much into the task orientation and they're not getting professional fulfillment out of the role. And our job is to create a practice environment that people can thrive and feel good about. And that doesn't mean that it's easy every single day, but to give people the resources, the support, and the ability to create transpersonal relationships that are meaningful for them in their career.
At Stanford, you have rooted the culture in caring science, which is about restoring human connection amid all the demands. What does that look like day to day, especially when the pace is high?
First, I want to give a shout out to Dr. Gene Watson, the theorist who developed Gene Watson caring science, and that informs our professional practice model at Stanford Health Care. It's giving language to what we do on a day-to-day basis. I would say, and Gene would say, that sometimes we get so busy doing that we can't be who we are. And our job with caring science is to assure that we're creating transpersonal relationships, because that's really where the theory lies with caring science, is giving the language and the literacy so people can create healing environments, so they can take care of themselves and others, so they can create miracles. When I heard that originally, when I was just learning about the caring science, I thought, oh, miracles, that sounds a little over the top. But in fact, we do see miracles every single day in the work we do. During the pandemic, we had a gentleman on ECMO, and that was a life support system to help with cardiovascular circulation. That individual said if he ever got out of here, he was going to come back and dance with the nursing staff. And he did. And there wasn't a dry eye in the room. That is a miracle. Sometimes we take for granted the work we do and we miss the miracles. But in fact, that brings tremendous joy and gratification to people that are providing the care, and certainly for those that are recovering from an acute illness. The science gives literacy and competency to help people achieve these transpersonal relationships above and beyond the doing and the task of what we do on a day-to-day basis.
That's such a powerful way to frame it in terms of giving language for what nurses already do instinctively, but often don't have the space or the words to name it. The example you shared of a miracle captures how presence and intention can change what is possible in care. In your experience, what's one magnet practice that truly moved patient outcomes and one that looked good on paper but didn't really change the bedside?
All of it changes the bedside. The impact of it may not be as big, but it's all intentional. I think the one that I'm probably the most proud of is we have moved our ranking in quality and safety in the country to number 5 out of 118 academic medical centers, and patient centeredness also to number 5 out of 118 academic medical centers per visit. Magnet is a framework that looks at quality, safety, nursing satisfaction, patient satisfaction, and gives you an opportunity to develop exemplars and interventions that will help elevate the health system as a whole. To sit as an AMC with those kinds of standings is pretty remarkable, and it speaks to the power of the bedside clinician and their ability to really translate a magnet into practice. We ended up getting magnet with distinction. There's only about 51 hospitals in the country that have received magnet with distinction, and we had 16 exemplars with our magnet designation. I'm proud of our magnet designation at Stanford because it's written by our nurses for our nurses. We don't bring outside consultants. We write our own stories, and it's embedded in who we are. It's not just an academic exercise that we do. It's practice on steroids.
I like that. Everything changes in the bedside, even though the impact can look different. One idea that often comes up in this context is psychological safety. It's something many organizations talk about, but few know how to measure meaningfully. How do you think about assessing and strengthening psychological safety in a way that links to nurse-sensitive outcomes?
It's a great question. The notion of psychological safety is a journey. I don't think it's something that you can say we've arrived in all areas in the organization. I think it's something you have to be intentional about and be very much aware about. You use the term presence in terms of being upfront and understanding what's happening. We actually do a cultural safety survey to look at psychological safety, and a nursing satisfaction survey. We just completed that, looking at psychological safety as well, because it's really important to improve high reliability within your organization. I'm a big fan of the whole concept of shared leadership. I believe you have to engage frontline leaders, clinicians at the bedside. We meet monthly about 450 to 500 individuals every single month to look at a practice, quality, satisfaction, nursing excellence, to get the voice of those doing the work into the work. The work we do is designed by frontline staff for frontline staff. And I think that is a great way to get things enculturated in your organization, to get adoption and acceptance, and to make sure you have accuracy. I sit here with a significant career in nursing and strong academic preparation, which is all fine and good, but that doesn't mean you know all the answers. You have to create a forum where others can use their voice, give you feedback in a way that you can design systems to support our patients in a much more comprehensive way. My overall answer would be make sure you're capturing the voices of those doing the work.
Hearing that you meet monthly with 450 leaders shows intentionality beyond the surveys that organizations do. And it sounds to me that it's a conversation that you're constantly having with them.
And here's the thing, it's chaired by frontline staff. They chair it, they set the agenda. I'm there as an advisor. So it's not me talking at people, it's them talking with peers and identifying solutions and problems that we have that we need to address as a health system. I'm there as an advisor. I have an element that I can add to, but I certainly don't have all the answers. But together, when you think about 450 to 500 people, when you put that many people together, chances are you're going to have a pretty good solution when people work together to come up with what we should be doing.
You're creating real feedback loops through this process of shared leadership. And I think it connects to something that you alluded to earlier about workforce development and designing a workforce, that it's not just about staffing numbers or ratios, but really about aligning work with people's strengths and licensure. How can nurse leaders rethink their teams through that lens? And have you seen a before and after example where that alignment made a real difference in outcomes?
So much of the work we do, like on the things you're mentioning, falls, eclampsies, the injuries that happen to patients, the solutions and answers are with those providing care. We obviously use the science that's in safety and quality and leverage that to the best of our ability, but then also making sure that we're developing systems and a culture that allows people to address what it is that we need to address. I mentioned shared leadership before, and that's a great forum where we can look at practice, we look at quality, we look at research to say, what is it that we can do to make it better? And I'm a big believer, it's not about me as a leader, it's about those at the bedside that are doing the work and how do they become empowered? How do you hear their voices? You mentioned psychological safety, and I do believe that when you're meeting on a regular basis for 8 hours a day, once a month, and then in other forums as well, practice makes perfect. And then when people feel like they're in forums where they can use their voice, they'll use their voice at the bedside. It's something that becomes enculturated that's important. And the expertise that we have in a place like Stanford is staggering. There is a lot of expertise, and you want to make sure that you hear all of it so that you're coming up with the best solutions at all. But again, I see sometimes people getting confused thinking it's about the chief nurse. The chief nurse is the facilitator or an advisor. It's the team, the clinicians at the bedside that make the difference.
What's an example from Stanford Health Care of a care model or workforce initiative that measurably improved patient care or team dynamics?
We actually built a new facility, opened up in 2019, 800,000 square foot enterprise that has an emergency department base and an inpatient tower above. One of the things we did in advance was to say, what do we need to do to redesign this building to be different than what others are doing that could have a big impact? We created what we call the Acuity Adaptable Unit, AU. And so most people have an ICU, they'll have an intermediate unit, and they'll have a med-surg unit. We combined our intermediate unit and a med-surg unit to create the AU. We wanted to reduce the number of handoffs from one unit to the next as patients progressed in their care. The literature is strong that every time you transition or you hand off a patient, there's potential safety issues in the handoffs in terms of communication and coordination. It's an expensive way to deliver business because you have to transfer patients physically, you have to turn their beds over, you have to clean them. And so there's a lot of logistics and moving a patient from one place to the next. Fast forward, we now have been in the building, 6 years? We have improved our quality from number 77 in the country to number 5, and patient experience has been number 5 as well. We've had great retention of our staff. We have less than 4% in vacancy and turnover. We've created a practice environment that speaks to quality, service excellence, and high retention of our staff. I believe models and structures are important. I'm a fan of Dr. Beatty, who studied quality. And one of the things that he talked about was the industrial engineers really focus on process and outcomes. And in healthcare, we have a lot of structure because we have people. So structure, process leads to outcomes. And so creating up with a new model of innovation and care has really driven process and outcomes so that we have a higher level of high reliability in the care that we provide here at Stanford. We're really proud of what we've been able to do in this particular area.
I think it's a perfect example of the long game in leadership, right? Decisions made years ago that's paying dividends now.
You have to be creative. I don't know any place in the country that has all their units AUs. I know people who have 1 or 2, but we took the leap to do it. It was a unique time because we had the opportunity to build a new enterprise with our new tower. We reset the new tower and the existing tower to have the AU model, and it has served us very well.
Thinking about long-term investment brings me to the next generation of nurses. As care models evolved, so must the preparation. What should nurse residency programs stop teaching in 2026? And what new competencies do you think should move from the nice to have to the core bucket?
So much has happened with the nurse residency program, and the Future of Nursing report that came out in the 2000s recommended fellowships for nurse residents. Many hospital systems now have them, many don't. I don't understand why they wouldn't, because the evidence is pretty strong that academia to practice can be difficult, and you really need to have structure and support to make sure you have a successful transition. A couple of things have pivoted and will need to pivot. Before, we focused on GPAs as an entry point. Now we look at more holistic interviews in terms of what skills, knowledge, abilities, and experiences individuals have coming into the health system. We moved away from a centralized plan for everyone to a more individualized plan because everyone has different skills, knowledge, and experience. and we want to customize how they develop. In the old days, we'd say you couldn't go into critical care unless you had XYZ experience. Now we do based on what the individual interests are and how we can best help skill build to make sure that they're successful in that transition as well. The last thing I would say, we made it easier for people to apply. We used to make it very difficult. And so that's a challenge. The other thing, we have been very focused on making sure that we have representation in our nursing workforce to that of our patient population. We've been very intentional about that because we know the literature is very strong that when you have racial, ethnic, language, cultural barriers, that can interfere with quality and safety for your organization. And so we have focused on making sure that we're recruiting a diverse workforce to match the patient population we serve.
That's an important evolution, moving to something personalized and accessible. And I think that kind of flexibility says a lot about how one views development as a partnership rather than a pipeline. It actually connects to something that you've spoken about before, which is creating systems where every nurse has a chance to grow and lead. You've talked about being the only one early in your career. From that lens, what system-level moves actually change promotion and retention for underrepresented nurses?
I started my career in nursing. I was the only man in my program, and it made me very uncomfortable. It gave me perspective. It doesn't make me a person of color, but it gives me a lens into what it may feel like to walk in a room where you may be different. We all need to be aware of that. I think it's important we create cultures and systems with people that inclusive and supportive of all. And so that takes intentionality. In leadership roles, we always hire the best and the brightest. And that includes that we assure that we have a workforce that's representative of the nursing workforce that we have. So that's been a huge change within our organization over the last 9 years. We'll continue to do that. And our outcomes have improved with it in terms of the retention of nurses and clinicians. And we've put a lot of time and energy in creating affinity chapters. We have a Black Nurses Association, Hispanic Nurses Association, Indian Nurse Association, and a Philippine Nurses Association, creating communities where people feel supported, recognized, heard, and celebrated. I'm really proud of the work the teams have done to create the culture we have here at Stanford.
Some of the things you shared are practical strategies to support and retain a diverse group of people, and that's really powerful. As a Stanford employee, I see posts around all the affinity groups at Stanford Health Care, and there's always some kind of community.
Thank you for that, Rue. I appreciate it. I've learned a lot of people say give someone a mentor, and I think mentorship's important. But if you have a mentor and you're the only person of color on your unit, the mentorship isn't enough. We have to create cultures of inclusion and community where people feel recognized, celebrated, and successful. I don't want to diminish mentorship because I think it's really important, but it isn't enough. We've got to find ways to have representation in the entire organization at all levels and to create communities where people can thrive.
Yes, mentorship is just one of the many things in the toolkit. In complex systems like Stanford, the strength of nurse, physician, and interdisciplinary relationships can make or break outcomes. What patterns have you seen that enable effective collaboration?
I've been a nurse for a long time, and I've always had strong physician relationships throughout my whole career. And I think my colleagues would say the same. That doesn't mean there aren't day-to-day conflicts, which I think you're referencing, but our focus is always around the patient and their families. And so we have alignment there. It's not about me. It's not about a physician. It's not about a nurse. It's about how we align to provide the best care for the patients we're serving. Sometimes there could be conflict and misunderstanding. Relationships could have challenges where someone doesn't feel comfortable saying what they think. And I think those are areas we really need to work on because we want everyone to be able to use their voice as best for our patients, even if it's in a different style. We need to stay open to that feedback so that we are using our whole brain for the organization and for the patient to provide care. At Stanford, we just got our nursing satisfaction results back. Our MD relationships, our interprofessional relationships are extremely high compared to the national average, around the 80th percentile. That doesn't mean there aren't opportunities to improve, but in general, we have very strong relationships. We have a preeminent school of medicine and preeminent nurses that work at Stanford, and it's through our relationship and expertise we really lift the enterprise.
Centering the relationship on the shared goal of the patient really resets the dynamic.
That's right. It's like when you have children, your children always are your primary focus. taking care of patients and families are our common goal, delivering excellence. That doesn't mean you're not going to have differences. And that's what makes us stronger along the way. But I'm really proud of the relationships with our physician colleagues here at Stanford, proud of the School of Medicine, and proud of nurses at Stanford Health Care.
The point about not just being about harmony, but the ability to speak up, get feedback, and stay open when tensions arise requires honesty, trust, and maturity on both sides, and speaks to the type of people that you would need in your organization.
That's exactly right. There are certainly great technical competencies that's required to be in this world that we're in healthcare delivery, but the cultural competencies is just as important. How we communicate with one another is significant. We have CI Care here that speaks to the behaviors and expectations of our organization. And I think it makes a difference to be very clear that we're a culture that expects that we collaborate for the best of our patients and their families. And you can feel that when you're here on a day-to-day basis. And the fact that we're number 5 in the country and patient-centeredness speaks to that as well. Our patients feel that.
That same spirit of openness and shared accountability would also drive innovation in the organization. So I'm curious, if you could make one enterprise policy change tomorrow to most accelerate nurse-led innovation, what would it be?
That's a great question. Number one, I just want to speak to, we're fortunate that we have nurse scientists here at Stanford that could lead a lot of our innovation. And I think that's critically important. I do think to allow nurses to drive their own primary research here at Stanford would be a big step, something that takes place, but in a broader way. How could we create policy changes that would allow for more innovation, more research, new knowledge to be spread? This is a great environment. We're proud of our nurse scientists that we have. We have many individuals that are part of the Academy of Nursing, recognized for their dissemination across the world. And so we've done a lot already, but more policy changes in terms of allowing nurses to lead some of the innovation would be helpful.
This may be the first time that I've heard the term nurse scientist. And we say physician scientist all the time. Of course, it makes sense that there are nurse scientists.
I think you're onto something because there's a lot of discussion right now about this is the age of the nurse scientist. We're just now moving into that where we realize it's important to have nurses that are truly focusing on research and innovation and have dedication. And what I'm seeing is health systems across the country now starting to bring in nurse scientists. Many don't have them. So to have PhD prepared nurses to focus on innovation is critically important. Your question was a good one. Maybe you didn't know what you were stepping into, but I think it's really relevant. And we're fortunate that we have the support for nurse scientists here at Stanford, and we're really proud of the work that they've done. We have a research nurse that just got recognized at the American Academy of Nursing for the Research Article of the Year on a concept analysis on health equity.
The term really elevates nursing from implementation to discovery.
That's right.
Which is really important, and a compelling reminder that nurses are not only delivering evidence-based care, but they are generating the evidence that shapes it. As you think about how the profession has evolved and your own leadership, I would love to close with a reflection. What is a belief you held 5 years ago about nursing leadership that you no longer hold, and what changed your mind?
I don't know if it's within the 5 years, but I had been a chief nurse a long period of time, and I did not have a doctorate degree. And I didn't think that I necessarily needed it because I'd been at a chief level for a long period of time. I went back and completed my doctorate in nursing practice, and it changed my career. I thought I was going back to check the box, but actually it opened my world into the notion of nursing science, nursing theory, nursing innovation, research, implementation, science, technology in a way that I didn't even begin to imagine. So I would encourage nurse leaders to continue to advance academically to make sure you have the skills, knowledge, and abilities that you need to lead your health system. When I think back on my own career, I think I did some great stuff, but I was limited. I would encourage everyone to pursue advanced education in these leadership roles because it does give you some skills, knowledge, and abilities that will help you do your very best. You mentioned innovation and creativity and even the caring science, understanding nursing theory and how to get that embedded into practice is critically important. We received a national award from the American Nurses Credentialing Center for our deep integration of Watson Caring Science into our educational platform. That would not have been possible without doctor-prepared nurses.
It's such a beautiful example of evolving leadership and realizing that even at the highest levels, there's always more to learn and more depth to uncover. And really, throughout this conversation, you've reminded us that nursing leadership isn't just about managing resources, it's about managing attention, nurturing cultures of care, and creating conditions where clinicians and patients can thrive. I'm so thankful for this thoughtful and inspiring conversation.
Thank you, Ruth. I think it's also about helping others and role model for the profession of nursing. We have almost 6,000 nurses within the health system, and it's really important that you role model the profession at its very best. I take that very seriously. I have colleagues that help. It's not something you do alone. Each one of us helps one another grow, develop, and advance. And I used to say I would stay within the Stanford Health Care system as long as I could continue to learn. I realized I could spend a lifetime here and still have an opportunity to learn. So that no longer is my goal. You can always learn when you're in a place like Stanford.
Thanks for tuning in. This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.